Welcome to 30 Minutes. I'm Rick Anthony. Several years ago, my late wife and I got on the list of a CCRC, that's a continuing care retirement community, as a hedge against the day when we wouldn't be able to stay in our home. It's a nice place, the one we decided on after checking out all the others in our area. Things have changed since then. My wife has passed away, and so my needs are quite different from what they were then. Smaller than what we had anticipated when we signed up. So to reacquaint myself with the facility and the options it offers, I'm going to take a tour later this month. I'm a bit apprehensive because when we first went, of course we were a couple, my wife and I. We saw our future together at that place. I'm going back as a widower, possibly interested in what they call a villa. Then again, maybe not. Maybe I'll stay where I am for as long as I can, which has always been my preference. It would have been a difficult decision if my wife had lived. At least we would have shared that facility, that place together. Now it's much more difficult. I'm one of thousands who have to make a difficult decision, life-altering decision in our later years. Luckily, I have a friend in the business, as they say. My guest today, John Whitman, has been an innovator in healthcare for over 35 years. I've only known him for about 25, but it seems like 35. He's now CEO of a senior living facility in Yardley, Pennsylvania, and true to form, he's putting innovative technology to work for the residents and the staff at the facility. John, always a pleasure to see you.
My pleasure to be here. Thank you.
And I know I can always count on something new with you. But I think you've really outdone yourself this time. We'll get to it in a moment. You must know and have run across many people, particularly in the position you're in now, who are faced with the same conundrum. What do I do? Do I give up the surroundings I've known for most of my life, all the things we've accumulated during our life that have sentimental value, if not intrinsic value? Do I really want to burden my kids with having to clean out the basement and start there and work their way up? You know what I mean?
Absolutely.
It's a tough decision.
It really is. And quite honestly, there's no good answer. It's an individualized answer. It really depends on each individual. And you mentioned earlier when your wife was alive, you were looking at a place. That's what forces a lot of couples to look, because one of the couple tends to be, their health tends to be declining, and therefore there's a recognized need for more support. And that's often the driving factor behind making these changes. You're in a totally different situation now because you really don't need that, and you can stay in your home. And I got to be honest, the preference nationally that you see from both seniors and from a government payment perspective, if you would, is to stay in your own home. That's where you're comfortable. You know things. That is the option that most people pick. Now, the reality is, as you stay in your own home, and as you start to deteriorate or have more healthcare needs, you're going to need some support at home. So, the options are go into a place like you've been looking at, or build an array of support around you so you can stay in your own home as long as you possibly can. Mm-hmm. There may come a point when you can't, when it's either physically or safety-wise not healthy for you, or economically it becomes impossible. But for the most part, more and more people are staying home and aligning themselves with the services they need to be able to do that.
As you know, it ain't cheap.
Oh no, it ain't cheap.
It ain't cheap, and it's getting more and more expensive. Yeah. Is there a profile of the kind of person who does well in communal living? I don't think I would do well in communal living. Sometimes I don't even like being with my family because it's so big.
Yeah.
I'm just kidding.
I understand. I understand. No, the long time is good.
Marlene and I talked about that a lot. Would we be comfortable living in an apartment with all these people around us? And we had concluded, at least for the time being, no, let's stay where we are and just wait it out.
There's some people that seem to fit better than others are ones that have very outgoing personalities. Yes. They're happy meeting new people. They're happy to get involved with different things. Unfortunately, a lot of people who end up going into personal care or assisted living or even some of these communities, they do it out of necessity. Yes. They can't stay at home any longer. And again, it happens more often when you have a couple, when one of the two is becoming seriously hampered in terms of their independence. But we get all kinds of people that come in, and it's funny because very often it's the children who are making the decision more than mom or dad, and it's typically for mom or dad's benefit because they're slipping in certain ways that does present safety problems.
Sure. Yeah. Well, on the other hand, there is an issue, again, as you know, if Marlene was still alive, and given her condition, it would be difficult to get into a CCRC because she has a problem.
Well, the CCRC...
So they look very, very carefully and closely.
They do, but one of the advantages of a CCRC is that, they have multiple levels of care. They have the independent living, they have personal care, memory care, skill care. And that was the whole appeal of those. They originally started, the Quakers were the founders of the life care community, if you would. And the original life care community was you sell your house, you buy an apartment here at a fairly substantial fee, and you pay a standard monthly fee for the rest of your life, and whatever level of care you have, they'll move you to. When people no longer, when they exhausted that higher income population that could buy it, then they moved to what's called the CCRC, where you don't buy necessarily, you rent, but you're also guaranteed that lifetime of services in one of the different levels as you need it. So in a case like you had when your wife was needing extra care, there's a lot of communities that would take you in a cottage, but then as your wife became more needy, she might move into personal care, for example. But yeah, and that's one of the disadvantages of the life care and CCRCs is you have to have money to go into those. You have to have an ability to pay for that.
Well, you just touched on something. Help me with the distinction between a CCRC, which is comprehensive care, and another, and I think you touched on it, is senior living but without health care. With all the other benefits, food and so on, but not health care.
A lot of the senior communities, like the Marriotts and the Toll Brothers, if you would, 55 plus living, they're aiming at a younger elder population that's still active and still healthy, if you would, and they have all kinds of meals and activities and swimming pools and programs, but they don't have the assisted living, they don't have the nursing home. So as you age in place there and you need any of those services, you've got to go to a different facility. So it's serving a niche market at that time, but there's a point in the future where that may no longer serve their needs.
I understand independent living, the 55 and over and so on. But even below that, for people my vintage and a little younger, it was CCRC, which I understand, but there was another option, and it was, and I've forgotten what the phrase was. It was continued living or something like that, but it didn't have health care, nor did it necessarily have the other step-ups. It'll come to me probably in an hour or two.
Yeah, I do it all the time. There are communities that are just retirement communities, if you would, or boarding homes. There's a variety of facilities like that have the one level of care. And again, the disadvantage from my perspective is people age, and as they age, they have different needs. And if you're able to stay within the same community and just move to different levels, there's an advantage to that.
I've noticed that most of the majors, the big brands, are now, I get the letters all the time, are now offering relocation services. They have seminars and workshops to help you deal with what I mentioned before. It's not as daunting as it seems, or even if it is, we can help you through it to get everything out of the house in boxes, get down to something that's manageable so it'll fit in that little two-bedroom apartment you're going to be moving into. And they're free services.
And that downsizing is a real issue for a lot of people, some more than others. I mean, you get some people that are borderline hoarders, if you would, and the volume, the level of stuff they have. My wife and I we moved to Florida for 4 months to do that research project I mentioned. So we packed up our house and we filled 154 of these big black containers. Well,
that was only for 4 months?
Well, that was what we had in the house that we put into storage when we went down to Florida. But most of that was the kids' stuff. We have 7 kids.
So you should have gotten rid of it anyway.
That's right. But it is a process. There's no question about it. And then you can also get the family problems about who gets what, who do you give what piece to or what,
Well, it's even worse than that.
Yeah.
When the kids don't want your stuff.
yeah.
And I hear that from so many people my age.
Yeah.
They don't want the dining room. They don't want the bedroom.
Yep.
They don't want the living room set.
And I took some stuff from my mom and dad that my wife didn't want when I got it home. She says, "What'd you bring that home for?" Yeah.
It's up in the face.
Yeah.
Now, from an industry standpoint, have senior living facilities fully recovered from COVID?
No, they really haven't. COVID did a number on healthcare in general from a couple perspectives. First of all, most of them shut down, so you couldn't have visitors coming in and all, and it really stalled admissions.
It was terrible.
It was terrible. And the other big impact that a lot of folks probably don't realize is it had its toll on staffing as well.
Yes.
Staffing is what makes a facility really good. When you get good staff, you train them well, they understand and know the residents, and they interact well. But with COVID, there were so many people that quit and so many people that did not want to go into healthcare that we're still using agency staff. And not,
It's expensive.
it's very expensive. And not all agency staff is bad, but the reality is you get somebody that's coming in, it's a part-timer, doesn't know the residents, doesn't know the people, and they don't even know all the things they're supposed to do, so they rely on the full-time staff to educate them. And the full-time staff is saying, this person's getting paid more than I am, and I'm teaching them, and I'm doing half their job. So it's a morale issue as well. So they haven't fully recovered. Census is starting to go back up. People are losing the hesitation they had in the past. So we are seeing that. But staffing continues to be a problem and will be for some time. The frustrating thing for me is we have so many issues with immigrants and the borders that we could use those people. It's like, I can't understand why somebody isn't looking at that problem and trying to solve part of it by bringing them into the workforce.
Yeah. Well, when Marlene was she was in rehab for a couple of weeks during her illness. And the problem was I couldn't understand some of not the skilled nursing care, but the
aides.
The aides.
Yep.
They would come in and have a heck of a time understanding just to get a menu straight.
Yeah.
Or understand what the problem was, what Marlene needed. They were nice. They were really nice, and they were well-intentioned. But the language barrier was a serious issue.
It can be.
And it's scary as well. I don't have to tell you. They make a mistake because of a language problem, a misunderstanding on medication or whatever. And you've got serious liability issues.
Yeah, you do. One of the problems with all long-term care facilities is the whole liability piece. And it's a shame because it's over-exaggerated. You got lawyers out there sending letters out to the nursing home where there was a senior care facility saying, did they ever miss a medication? Do you have a bruise on your arm you can't explain? And they're ready to sue the organization for things like that. And a lot of people in nursing homes in particular will break their legs or their hips or they'll fall. But a lot of times when they stand up, that's when the bone breaks and that's what causes them to fall.
Yes.
If that happened at home, there'd be no question. But if they're in a nursing home, people just expect there to be a nurse's aide on each side to help them up and down every time they get out of the chair. And it's not reality, but it's a problem.
You're an innovator. You're a problem solver. You've got a creative mind. Other than taking a whole bunch of immigrants and training them, what other solutions are there?
Well, there's a lot of solutions. We've got to use technology better to expand the capability of our staff. And by that, there's a couple things. I mean, there's all these remote patient monitoring type devices that are out now, both for the nursing home and for the home. For example, if you have congestive heart failure, okay, which means if you put on 3 or 4 pounds, you're going to end up in the ER. And you put 3 or 4 pounds on if you sit and watch the ball game and eat a bag of potato chips. And you got to admit, we're not the most compliant people in the world. So we do that. But if you have remote patient monitoring with your weight, in the morning you step on the scale, it's automatically transmitted. At night you step on the scale, it's transmitted. And when you sign up, your baseline is put in there. So if you gain more than whatever the doctor specifies, 3 or 4 pounds in a short time frame, it alerts the doctor so that he can reach out to you and say, how was that bag of potato chips? And I need to increase your Lasix for a day or two to get it down. And without that intervention, you for sure would end up in the hospital with a medical crisis. These devices are nothing more than an early warning system.
Yes.
They give us time to react to a potential problem before it escalates to a serious medical crisis.
The assumption is that there are enough docs on the other side to see the alert and to come up with a remedy.
Well, the good
Or
news
is that
with
going
that
to be
is,
automated too?
well, the automation comes with anybody that goes over the certain limits.
Right.
That alarm is then set out, and it could be a nurse practitioner, it could be the doctor. Most of these programs are set up so you have a nurse that does that initial intervention to make sure there's truly an issue, and then if it can't be resolved, then the doctor gets called in. So there's not a staffing issue so much on that problem. And one of the other reasons I like it so much is you don't have to have. The doctor doesn't have to go to your house.
Right.
I mean, it could be an older doctor, a retired doctor, it could be a handicapped doctor. So it expands that workforce capability to get those things done. You know, that's just one example. There's all kinds of automation available. One of the things I'm looking at right now that's really exciting is what they call social robots. There's a company out of Texas who's joined with a group in India, and they have a social robot, stands about 4 foot tall, has an iPad as a face. Now, it's not like the robots in Giant that you always seem to want to trip over. No. By the way, did you see last week one of them got out, was wandering around the parking lot? It's really funny. But anyway, no, it's about 4, and it's got facial recognition built into it, and it's got AI built into it. So I'll roll up to you, for example, and it'll say, "Hey, Rick, how you doing today? Do you want to hear a song? Do you like Frank Sinatra? Do you want me to play the music for you? Do you want to see a short video?" And it can engage you and start in conversation. And for me, for those early dementia patients who lose the ability to engage quite a bit, that's incredible. It's a great way to get them.
So that's generative AI, artificial intelligence. And does it learn?
The artificial intelligence is that if I play you Frank Sinatra today, tomorrow, the next I roll back, and I know it's you because I have my facial recognition.
Right.
Did you like that Frank Sinatra song? And it learns your quirks and things you like and don't like, and it can adjust to them. So it's really pretty cool from that perspective.
I did look at the, I guess, the video for the promotion piece. And there was one clip that got me. The machine said to the older lady, "I love you." And she looked back and said, "I love you too."
Yeah.
Is that good or bad?
No, I think that's
wait a minute.
good.
Isn't there a risk that they become attached to machines? I've heard that argument.
You know, they've been using these in Japan and some other countries much longer than they have in U.S. And I've read a lot of the research and pulled a lot of the information on. I've never heard that as an issue. A lot of people are fearful that seniors will be scared of or won't interact with robots well. And they said the same thing about telemedicine. But guess what?
Sure.
None of the studies have proven that out. People adapt very quickly to that.
You told me also about a television screen.
There's a company in New York that has, let me take that back a step. One of the problems with a lot of seniors using technology is they can't use an iPhone well or an iPad or a computer. There's a company out of New York that's developed an attachment, a box that goes on your TV, and your TV remote control now controls everything. And that TV is now a command center, if you would. You can do telemedicine through it. The senior can call all their families and do Zoom calls over the TV. You can attach remote patient monitoring like the weight, the scale, blood pressure, blood glucose levels, whatever you need for you. And what I love about the doctor telemedicine interaction is that, you know, a lot of seniors, there's a huge population of what I call medically isolated seniors who can't get to and from their doctor's office. They just physically can't do it. They don't have transportation. And with this remote patient monitoring and the TV, I could do a visit every couple of days with you, every month or whatever's needed, and see how you're doing, talk to you, see you in person.
So there's the camera that...
Yeah. So there's some really cool stuff out there coming in. I got to tell you, it's just the tip of the iceberg. There's a toilet seat they have now. As unclassy as that sounds, a toilet seat that measures whether you have a urinary infection or whether you're dehydrated. It does
the analysis?
It does the analysis and can alert the staff or your doctor that, hey, you're on the verge of, and therefore you can take medication. Because urinary...
That's a big issue, isn't it?
Urinary issues are a major issue because people who contract them, and when they go for... I mean, you become combative sometimes, you become confused, it can kill you. So by using this as an early warning system, we can prevent that. Some very cool stuff.
And is this innovation is coming from us, or is it coming from other countries like Japan, China?
All over the world. This TV thing is out of New York City. The toilet seat is out of Israel. I mean, there's stuff, and the robots are out of, this particular one is out of India, but there's been many in in Japan, and there's other places in the U.S. I mean, the robot concept is not new.
No.
And in fact, some facilities are using it now. These are kind of modified robots, so they'll do sweeping of the floors,
Yes.
but it's all self-controlled.
Yeah.
They have meals. They have robots that'll deliver meals and pick up dirty dishes and bring them back. But this one I'm looking at, and that level, have more direct interaction with residents.
Can the robot you're describing dispense medication?
Not yet. No. And I'm not sure if you want to do that yet, because there's still the potential for problems.
Yeah.
I mean, medication is a huge factor in terms of accuracy. And one of the big things we're working on across senior care is decreasing the number of meds. Too many seniors are on too many meds for too long a period of time.
Yes.
And it goes back to a problem with our healthcare system. Our primary care docs, who are supposed to be the captains of the ship and kind of monitoring all that, a lot of times if you have a urologist or a cardiologist or whatever, that they don't want to mess with that because that's not their territory.
No.
But that's where it should be controlled.
This revolution and evolution of technology in facilities like yours.
Right.
Does that also benefit people like me, an unpaid family caregiver, to take care of a loved one at home?
Yes. Well, first of all, the remote patient monitoring helps tremendously.
Yes.
That is a really strong one. You know, the telemedicine, so that you don't have to drag mom to and from the doctors. Now, there's some doctors where telemedicine doesn't work. I mean, there's, where you have to have a physical exam. But for basic primary care stuff, it works very, very well. And I'm looking forward to, and I don't think it's that far away, till these robots are available individually in the home as well.
So we can talk to the robot, not to relate to the physician or the clinician.
Yeah, yep, and the robot is programmed to look for certain things or hear certain things. For example, in the nursing home, if I'm talking to you as a robot and you say you're in pain or you have to go to the bathroom or something that requires a response, that robot automatically signals to the nursing station and says, Rick's got an issue, you got to come see him right away. Right. And that's pretty cool. It's extra eyes and ears.
In the home, is this technology covered by Medicare? All of it?
The remote patient monitoring is all covered by Medicare right now, which is pretty darn cool.
Those are the devices.
All the devices that check your vital signs, whatever your issue might be, whatever your chronic condition might be. That's all covered by Medicare right now, so there's no cost to the individual. The robots haven't quite gotten there yet. They may at some point. The TV is not covered, but they're trying to link it with remote patient monitoring so there'd be no cost to the patient. And most seniors, particularly the ones who would benefit from the TV, have chronic conditions going on so that remote patient monitoring is appropriate.
Yes.
I'm very much opposed. Some of these remote patient companies will say, you're 65, I can put you on 7 different monitors. And that's ridiculous. That's milking the system.
I'd like somebody to come up with the technology to eliminate having to put the cuff on and constantly taking blood pressure, which was Marlene's issue. It was all over the place.
I just saw a program yesterday and I tried. It's very cool. It's on a phone and it'll be on that TV where they put a program up and you put your face, you look right into the camera into a certain thing, and it can take your blood pressure, your pulse, your oxygen level.
Just facial?
Just facial, looking at it, yeah.
Wow.
I mean, you talk about cool stuff. I mean, it really is amazing what's coming out.
On the one hand, we need them to make up for the shortage of nurses and other. On the other hand, it's going to displace a lot of people. So maybe we're not going to need to fill those positions.
I hope we come to that, but I really don't think we will because there's such a shortage right now. And the reality is all these devices are going to help us keep people alive longer, which is a good thing.
Yeah.
But when you look at it from a global system standpoint, now we have that many more seniors living.
With marvelous for third world countries.
Yeah.
Who don't have access to.
The other group that's being looked at heavily for a lot of these things too is veterans, because there's a lot of veterans that have a lot of medical needs that aren't being addressed, and isolation and their ability to get to and from the hospital. So that New York City group with the TV monitor, for example, that's one that I think is going to really take off with the Veterans Association.
And that'll be covered?
The VA, I believe, will cover that for vets. That's what they're trying to accomplish, And again, for regular seniors, as long as they attach a remote monitoring device or two to it, it won't cost the individual anything.
Yeah. I have to ask you about TRECS,
Okay.
TRECS, which has been a love of yours and a labor of love for a long time.
Absolutely.
What, 20 years?
About 17 right now.
17,
it stands for Targeting Revolutionary Elder Care Solutions.
Say it again. What's the acronym?
It stands for Targeting Revolutionary Elder Care Solutions. My kids came up with that name at the dinner table one night. I was complaining about not being able to do certain things, and they said, do it. Stop complaining and do it, out of the mouths of babes. So anyway, we did it. And TRECS is a nonprofit. We do a lot of research into improving care for seniors. We started out with a lot of work in dental care for seniors in nursing homes, which quite honestly was almost non-existent. We've improved that dramatically. We came up with a groundbreaking study that introduced a whole series of private insurance policies, specifically targeting the Medicaid, the population that can't afford it. But there's a quirk within the regulations that they don't pay for it directly. It gets paid for. So it's been a wonderful program. And it's now in about, I think, 38 states. We've done a lot with remote patient monitoring. Recently, we've done a lot with telemedicine. We just finished a project in Florida where we put telemedicine in 28 facilities, 28 nursing homes. And the goal was to prevent people from unnecessarily going to the hospital. Right now, the system we have in nursing homes is antiquated. I mean, if you're the doctor and I'm the nurse at the facility, I call and I say, Mrs. Smith's having a fever, having chest pain or whatever. And your only response, quite honestly, is send them to the hospital because you can't tell over the phone. If it's something serious, you don't want to get sued. You want the patient to get the best care. So, but, probably 60% of people that we send to hospitals from nursing homes, when they go through there's nothing there.
Yes.
A very common one is chest pain. They'll complain of chest pain. Doctor thinks it's cardiac. It's a pulled muscle between the ribs. With telemedicine, the telemedicine doc will have the nurse palpitate down between the rib cage. And if she hits a pulled muscle, that patient's going to let you know. And it's 2 aspirin, a little lidocaine, and I'll check on you in the morning, as opposed to an ambulance ride, sitting in the ER for hours.
$15,000 bill.
Exactly. So there's been estimates that telemedicine in nursing homes can save CMS upwards anywhere between $1 to $3 billion a year by preventing those hospitalizations, which is fantastic. Best thing is, it's the best thing for the patient. Sending a patient to the hospital is not quality care.
So TRECS is involved in a number of demonstration projects?
Yeah, there are grants from CMS to look at the effectiveness of these types of programs. And that Florida study, we found in 1 year we saved 463 people from going to the hospital. That saved Medicare about $6 million. It brought additional revenue into each of the facilities, and it was obviously the best thing for those patients.
From a caregiver standpoint, it at least theoretically relieve some of the stress of caregiving. Because I'm not guessing as much. Again, when I was a caregiver, I spent so much time not knowing enough and not knowing what I didn't know, so I was calling the doctor constantly, principally for medication.
And that's why a lot of people that go home from the hospital with a caregiver end up coming back. It's not so much the patient that wants to come back, it's the caregiver because of their concern, and if they're not medically trained at all, that's why, again, I think the telemedicine at home is so critical, because if I want to, as soon as that TV is ready, I'm going to put it into our palliative care program at Chandler Hall, because we have about 100 people in that program, and we get calls at 2 o'clock in the morning with a concern from the caregiver about the patient. And probably 70% of the time, it's nothing serious, yet we send somebody out to the house. Once we get this thing equipped, we'll be able to do a telemedicine evaluation and talk to the caregiver, calm them down if it's not a serious issue, let them know what's going on, give them the peace of mind they need, and then if necessary, somebody can go out in the morning. So that's a win-win. It's a win for our program in terms of keeping costs down, and it's an absolute win for the family and the caregiver.
You must get an awful lot of satisfaction knowing that the work you're doing and some of the innovations that you're tracking, promoting, and enabling are not only making life better, but saving lives as well.
It is incredible. But the simplest thing, I got to tell you, a couple weeks ago, I stopped. I do a lot of management by wandering through the facility. Yeah. And there was about 7 o'clock in the morning, there was a lady in the nursing home sitting in a wheelchair. And I walked up to her, and I introduced myself. I said, "How you doing? What's your name?" And she said, "Oh, my name's Anita." And I got this big smile on my face. I said, "Anita, I had a girlfriend in high school named Anita. You just brought back so many good memories for me."
Yeah.
And I sat and talked with her for 3 minutes, 4 minutes, not long at all. And I got up and I shook her hand. I said, "Anita, you made my day." And she looked at me with the most sincere eyes in the world and said, "No, you made my day." Just by talking to her for a couple of minutes. I mean, it really is amazing.
John, it's been a pleasure.
Absolutely. Thanks for having me.
Thank you very much. My guest today has been John Whitman, a good friend and an innovator in healthcare who's helping an awful lot of people. Until next time, this is 30 Minutes. I'm Rick Anthony. Take very good care of yourselves.